here today with Amy Finkelstein, who's a professor of economics at MIT and also the co-author of this book, We've Got You Covered, Rebooting American Healthcare. Also co-author of this book, also with Liran Einav and Ray Fissman, Risky Business, Why Insurance Markets Fail and What to Do About It, and also this short lecture you gave a while back called Moral Hazard in Health Insurance. Welcome, Amy.
Thanks so much for having me.
Well, I think it was in this book, Moral Hazard in Health Insurance, that you referenced Ken Arrow's seminal article, which I guess was sort of the creation of health economics back in the day.
Many people date the origin of the field to that 1963 article.
Yeah, but of course it was also about insurance economics, right? And so whenever we learn about insurance in economics, we learn about moral hazard and adverse selection. And these are the things that make insurance markets particularly tricky and difficult. And of course, in the U.S., healthcare in particular, health insurance in particular, is a crazy market. And the problems that people focus on are, on the one hand, the rising cost of healthcare, which has just exploded and now is probably $1 in $5 in GNP, and also the inequality of not only health outcomes but also access to healthcare. And some people treat these things differently. I think one of the points that you make is that they're connected to some degree, and that the trends in insurance have led to, in part, the explosion of our healthcare costs. And in this book, this latest book, you make a distinction between a fixer-upper and a tear-down, and you say that the healthcare system in the U.S. is not a fixer-upper. It's a tear-down. And when we take a look at it, it's just so full of patches and Band-Aids that no sensible person would have ever invented a system that looks anything like what we have today, and it's almost beyond repair. And so I think the book says if we were to start from scratch, we would do something very, very different. And a big chunk of that is going to be universal basic health care. Now, I think some people were kind of surprised because they say, oh, you're one of the leading experts on moral hazard, right? And so wouldn't we expect an expansion into universal health care to just exacerbate the inflation of healthcare costs? And you argue that it will not do that, but will probably actually help to contain them. So where do we get started? I don't know. Why is it a teardown and not a fixer-upper?
So you've made a lot of good points. I'll start by responding to your question, and I'm sure we'll get to the others. I think, there's two ways you could think about it being a teardown. One is a key purpose of our book, We've Got You Covered, which I wrote with Liran Einav, is to say, let's step back and ask, freed from political constraints, but obviously not economic constraints, how would you design an ideal system? And, in principle, one could then compare it to what we have and figure out what tweaks are needed to get from A to B. In practice, the current system was never designed or planned. So it's not like someone built the house and now it's, slowly, gotten out of date and dilapidated. It was sort of thrown together haphazardly as particular needs sprung up, as particular issues became politically salient. And so in some sense, once we saw where we wanted to get to, which is in some sense the main focus of the book, it became pretty obvious that we couldn't get there through just a series of small incremental reforms. Part of it is because, one of the things we focus on when we worry about insurance coverage in the United States is, the 30 million Americans who lack health insurance at any given moment in time. But that one thing Liran and I discovered as we worked on the book, that in some sense, while it's a very important issue, really understates the problem, because a much larger share of Americans, we estimate, about twice as many, 1 in 4 Americans under 65, will actually spend some substantial period of time without health insurance over a 2-year period. And the reason for that is highly related to the sort of patchwork, Band-Aid, Rube Goldberg machine system that we have today, which is many people are eligible for insurance, but fail to realize which way they're eligible, or fail to recertify to maintain their eligibility, or their health status or their income or their age changes slightly and they lose eligibility for one program and need to get on another. And so that's why you have a lot of, people experiencing spells without insurance coverage, not because they're not eligible for anything, but because when you have all these complicated different pathways to get coverage depending on which disease you have, where you live, what your income is, what your age is, etc., you often find people who just can't find their path or fail to stay on it.
Yeah, I was really surprised at how complicated it was. I think for people like myself who have had more or less consistently access to some health insurance through their employer, that you don't really realize how patchy it actually is.
I think that's right, but I think it's also, almost everyone who's privately insured, which is about half the population, as you said, is getting their insurance through their employer. And that, actually can create a fair amount of this uncertainty or this insurance, turnover. If you lose your job, change your job, retire, become ill and therefore lose your job, you can lose your health insurance. And that's not a particularly sensible way to design a health insurance system. The very purpose of health insurance is to provide some modicum of economic and financial security in a insecure and uncertain world. So it's quite perverse from our perspective that health insurance is itself highly insecure and highly uncertain. And you asked why did it get that way? I think because, as I said, there was never a let's start with a clean slate and figure out how to build a coherent system moment. There was let's create insurance for the elderly, for the low income, for low income women with breast cancer, for low income individuals with tuberculosis, for people with end stage renal disease. The list goes on. And so you can see then how it can be hard to figure out exactly where you slot in or to maintain yourself in that slot. I mean, one of the things that I think is particularly perverse is that, for example, there are many of these disease-specific health insurance programs, which of course are well-intentioned and come out of a, desire to help people in particular circumstances. And I always thought, well, that's great, but we should have it for all diseases. But I realize it's actually much worse than I thought, because if you have end-stage renal disease, for which there is universal coverage, and you're fortunate enough to get a kidney transplant, which is rare because you need to match, and there's a limited number of donors. But if you're fortunate enough to do that, that's great for your health. You no longer have your kidneys now work, but that's bad for your health insurance because you no longer have end-stage renal failure. You now have working kidneys, and so you will lose your health insurance coverage, despite the fact that you have to stay on immunosuppressant drugs, which can cost tens of thousands of dollars a year for the rest of your life.
Yeah, and one thing I didn't realize is that wasn't that long ago when health made up about 5% of our GDP. I think it was 1960, the numbers that you showed. And back then, most people didn't have health insurance. It was, it's a relatively new industry, this whole idea of health insurance. I mean, why is that? You talked in the other book about auto insurance. And, life insurance has been around for a really long time, and it's had its problems, of course, and it's led to a lot of financial problems for those governments that issued annuities and so forth. But why has it been so recent that we've seen health insurance?
That's a great question. So, the term health insurance is a bit of a misnomer. Health insurance doesn't actually insure your health. It's not, providing the fountain of youth. That would be wonderful. Instead, it's providing, as I said, economic or financial protection against the medical costs of poor health. And, for much of human history, those medical costs were quite low because medicine itself was quite ineffective or worse. It was
Mhm.
could be counterproductive to health, and it really only was starting in the late 19th century with the advent of the germ theory of disease and progress that physicians act and invention of ether and the x-ray, et cetera, that physicians actually started to be able to both understand, you know, the sources of illness and to treat them. And so that's a wonderful thing for population health, but then that made, the doctor or the hospital much more expensive and, sort of meant that before, if in the earliest forms of what often is referred to as health insurance in the late 19th century, Bismarck and Germany were really much more income maintenance programs. They were ensuring the lost
Mhm.
income if you fell sick. The actual medical costs of falling sick were low because there wasn't much that physicians could do. As they got to do more, that meant that there was just more uncertainty about your medical bills, and that's exactly what insurance is designed to protect, right? You talked about the healthcare, delivery and costs. People now bemoan that, the old days when the doctor might pay a house call are long gone. Well, one of the reasons the doctor could pay house calls before is that, he couldn't really, when it was usually a he back then, couldn't do very much. So they might as well, take the time to at least, be a supportive and nice person. Now, the opportunity cost of a physician's time is quite high because there's a lot they can do, and but that also makes it more expensive, and it means the risk of if you get sick rather than die, you might have an expensive, say, cardiac procedure. That's great, right? That's better than dying, but then we need insurance to cover it. And I think that's really why you see health insurance taking off in many countries, in the post-war period.
But we did have these charitable hospitals, right, that would take care of people, particularly the indigent. And I think you mentioned that meant that you had to kind of sort between the kind of deserving indigent and the undeserving
Yeah,
indigent.
so again, this was really surprising to me. So hospitals, date back, there were hospitals in the 18th century and early 19th century, long before anything that we would consider as, modern or even, quasi-modern medicine. But these were primarily charitable, not medical institutions. So basically, in the late 18th and early and even mid 19th century, the sort of standard of care was, rest, relaxation, and light nursing in the home, sort of the original family practice, if you would. And, hospitals sprang up because in the newly forming cities where people were no longer necessarily with their extended family and in small tenements rather than larger houses in rural areas, it was hard to nurse and care for people in their home. And there was in the Victorian era a real obsession with this idea of people who were destitute through no fault of their own. And it was considered, you could become sick and through no fault of your own, but if you were otherwise destitute, the poorhouse was designed to be sort of an incredibly unpleasant place because it was, trying to get people to, not be what was perceived of as lazy and in and to work instead. The view was if you were sick, though, that wasn't a moral failing, with some exceptions. So, for example, if you had a venereal disease, you were treated differently. But if you just had generic illness, the hospitals sprung up as charitable institutions. They were philanthropic. They were, what pillars of the community would support. You often needed a letter of recommendation attesting to your good character and moral fortitude to be admitted. I mean, it was really trying to separate people who were destitute via illness as opposed to people who were destitute through perceived, indolence. Really not a medical construct at all.
Yeah, and you talked about the first case in America of, I guess, mandatory health insurance, which was in 1798. I found that fascinating, but it
Yeah,
makes
that's one of my
it makes a lot of sense.
Yeah, it's one of my favorite facts of the book, which is, we tend to think of the US, and it is now something of a health policy laggard, particularly in, health insurance. We're the only high income country that doesn't currently have universal health insurance coverage. And so it was amazing to me to discover that we were, in fact, the very first country to introduce national compulsory tax financed health insurance. And you stole the punchline, but yes, it was in 1798. And I think it's not just a mere sort of cocktail party curiosity. I think the reason it was introduced speaks very much to what still remains, I think, the fundamental purpose of of government policy in the health insurance space. It was introduced, it was called an Act for the Relief of Sick and Disabled Seamen, and it was for people in the merchant marine. And the way it worked, it was really it's quite modern in some sense. There was a payroll tax, a deduction of 6 cents per sailor per month at sea. When the sailor arrived at port, domestic port, that was supposed to be deducted from their wages by the captain, handed over to the customs agent. And the reason for it relates very much to what we were just talking about the charitable origins of hospitals, is that, there was a real charitable impulse that, as, the historian of medicine, Charles Rosenberg, puts it in his book, that fellow creatures should not be allowed to die in the street, that if people were ill and didn't have the resources to get care or have family members who could provide care, that charities would step in to provide that care. And sailors fell very much into that category. They would often become sick while on their sea journey, and then they arrived at port, separated from their family who would live elsewhere, and they became a burden on the local community. It's no coincidence that the early hospitals were in port towns, New York, Philadelphia, Boston. And the problem was these sailors coming from all over the newly formed country would become a concentrated burden on these few port towns where they would arrive ill. And so none other than, Alexander Hamilton, when he was Secretary of the Treasury, argued for this bill by saying, essentially that if inevitably we're going to feel, compelled to provide local charity care for sailors when they fall ill, we might as well recognize that and formalize it and fund it up front through a payroll tax so that it doesn't become a concentrated burden on the, philanthropically minded citizens of these few cities. And at scale, that's very much, I think, an argument for universal health insurance that persists to this day, and that you can see, voiced by people across the political spectrum. So universal health insurance is an argument that's usually associated with progressives and the left, but you see people more conservative-minded, both intellectuals and policymakers, using this exact same argument. Friedrich Hayek, who's a well-known conservative economist, from the early 20th or mid-20th century, who railed against the British National Health Service as government intervention in markets. Even he said, well, of course we need some kind of universal health insurance, because inevitably we're going to, when people become ill, feel compelled, not just as individual citizens, but as taxpayers, to step in and do something. This was exactly the argument that Republican Governor Mitt Romney made for universal health insurance in Massachusetts, which predated Obamacare by a number of years. I think one of the most interesting arguments I heard or from an interesting source, is from the libertarian Charles Murray, who also argues for universal basic income, another idea that's often associated with progressives. But he argues for it as a way of trying to get the government out of people's lives, to dismantle the bureaucratic state and give people back people's their hard-earned money. So he would get rid of all transfer programs, and instead give everyone I think $13,000 a year universal basic income, as a way of giving people power back over their own earnings. And he makes in this entire book, one and only one exception to this idea of getting the government out of people's lives and giving people autonomy over their income. And that's to say he's going to claw back $3,000 of that $13,000 to use it for compulsory health insurance coverage for everyone. Why? Because Murray also recognizes, as did Romney, as did Hayek, as did Hamilton, that even if you've given people universal basic income, if they choose not to spend it on health insurance and they end up sick, we will not be able to help ourselves as
Hmm.
taxpayers to from stepping in and trying to provide some care when someone is extremely ill and unable to afford that care themselves. And many
So,
and you oh sorry, go ahead.
no, finish.
I was just going to say, you mentioned life insurance, auto insurance. One thing that's, I think, certainly very different and perhaps unique about health insurance compared to almost any other form of insurance is that the risk that's being insured is not something that scales with your income, right? Life insurance, you're insuring, part of your earnings and salary if you die. Disability insurance as well. Auto and home insurance are, insuring your car or your home, which people who have higher income tend to have more expensive cars and homes. Uh, Health insurance, you're insuring the medical costs of poor health, which don't really scale with income, right? A heart attack is a heart attack, and if anything, it's the opposite, because lower income individuals tend to be in worse health. So this idea that you really could not afford your health insurance or your health care is meaningful in a way that it's a little harder to understand, in the case of, say, auto insurance.
But what you're saying is that we can't really credibly commit to not help people when they're in need. And
Exactly.
so, so, and that of course explains why whenever we try to put in place deductibles and co-pays, we typically will wind up figuring out some way to help those people with the co-pays and the deductibles if they can't afford it ex post, right?
No, exactly. You mentioned earlier on the work that I and others have done on moral hazard and Ken Arrow's original article. There's a long and storied intellectual tradition in economics documenting empirically and quite rigorously that when individuals have to pay something for their medical care, they tend to use less care. There's been
Hmm.
randomized experiments showing this. I've done some of that work. Many others have as well. And from that, and there doesn't seem to be much health consequence of, these small copays and deductibles. And so from that, the sort of conventional wisdom, which my co-author Laurent and I have sort of taught for years, written about as well, is that people should have a little bit of financial skin in the game when it comes to their medical care so that they don't rush to the doctor every time they sneeze or have a headache, and insurance protects the large catastrophic risks, but you have some financial reason to be judicious in your medical care. And in this book, much to our surprise, if you'd asked me before we started working on it, we say quite unequivocally we take that back. We were wrong. Not because the evidence is incorrect. We stand by the evidence that we and others have produced. It is true that when people have to pay something for their medical care, they use less of it and seem to be more judicious in their choices. But because the implications we drew from it were wrong, when at least in the context of universal basic coverage. And the reason we can see this, and it goes to what you were saying, is that we've seen what happens in countries around the world that have followed the advice of well-meaning economists such as ourselves and introduced small cost-sharing provisions into their universal basic coverage. Small co-pays, $5 or €5, €10, £10 for prescription drugs, vision, dental, etc. It's kind of amazing. This is often done in response to budgetary pressures, but what you see time and time again is that they introduce the cost sharing with the one hand, and then with the other they introduce the exceptions and the exemptions. So, for example, in the UK, which started out everything was free at the point of service that was covered by the National Health System, and then as they faced budgetary pressures, they introduced small co-pays for, say, prescription drugs and vision and other things, and then they introduce the exceptions for people who are poor, for people who are old, for people who are young, for people who have cancer, for veterans, for students. The list goes on and on. And so that basically recreating this patchwork mess that we have in the US for health insurance writ large on the small scale of prescription drug copays, so that at the end of the day, people have estimated that about 90% of the prescriptions that are dispensed in the UK are actually dispensed to people who are exempt from paying the copays. And so the reason we came out against cost sharing in universal basic coverage is not because cost sharing doesn't reduce healthcare spending. It's that cost sharing doesn't reduce healthcare spending when it's waived, exempted, and excluded. And inevitably that's what's going to happen, as we've seen in many countries around the world, because fundamentally cost sharing is in tension with the fundamental purpose we came to believe of government health insurance policy, which is to ensure access to essential medical care regardless of resources. There will always be people who cannot afford even a $20 doctor copay or a $5 prescription drug copay, and that's where we start getting all these exemptions and exceptions and kind of end up back in the mess we started. So our view is, let's keep the universal coverage basic in terms of what it covers, but whatever it covers, let's make it free to the patient, because the social contract is essentially about making sure that any essential medical care is available regardless of resources. And we spend quite a bit of time in the book discussing the evidence for that social contract, particularly in a country that doesn't yet have universal health insurance coverage, and some of the psychological reasons it may exist. Whether you agree with it or not, whether you think that social contract should cover other things as well, it's pretty empirically, we think, incontrovertible that we will not stand idly by as taxpayers when people are ill and unable to afford medical care. So we should, as Alexander Hamilton noted hundreds of years ago, formalize and fund that up front.
Well, okay, so let's suppose somebody accepts this idea that government's going to wind up stepping in to help people when they fail to buy insurance. We've seen it in coastal properties, right, where people, their houses get wiped out by a storm and the government comes and bails them out. So why couldn't we just solve this by mandating that they purchase some kind of private insurance? I mean, that seemed to be what the Obamacare was trying to do. It was trying to keep the private insurance model afloat and then just use these mandates to make sure that there weren't these unexpected governmental expenditures.
So let's distinguish between two things you said. One is, how do we achieve universal coverage? Do we do it with a mandate or by automatically providing it to everyone? And that's, though, distinct from the question of how do we deliver this coverage? And you can deliver, if you mentioned preserving private markets. I think there's a lot of research and I think pros and cons to having multiple insurers versus a single insurer, to having private insurers as opposed to public insurers, or both. Our proposal can be implemented through any mix and match of that. It can be implemented, through the single payer public system, like in Canada or the UK. It can be implemented through a competing set of private insurers, like is in Switzerland or the Netherlands, or any, mix and match of that you want. So I think the real question is not private insurer versus public insurer, but mandate versus automatic, right? And we've had experience with both in the US. We've had essentially automatic coverage for Medicare hospital and doctor insurance when people turn 65. That was introduced in 1965 and went off without a hitch, except in counties in the South that refused to desegregate their hospitals, which was a condition of receiving Medicare. But for individuals, the coverage was automatic, and that's why essentially everyone 65 and over has health insurance coverage in the United States. We mandated and we enacted universal coverage in 2010 with the Affordable Care Act, known as Obamacare, but we haven't achieved it. So mandating it doesn't make it so. So the reason we're not advocating for a mandate is simply because that didn't get us to universal coverage. And the reason it didn't is again this issue of the patchwork of different ways you can qualify. So one, I think, particularly sobering fact about the people who are uninsured is that there have been estimates that about 6 out of 10 of the people who are currently uninsured are actually eligible for either free or heavily, heavily subsidized health insurance. But they're not covered by it. Why? Because the research indicates either they didn't realize which program they were eligible for, or they weren't able to assemble the requisite documentation to show that they were eligible for the program they were eligible for, or they actually got on the program and then failed to recertify their eligibility. Because whenever there are different little patches that get you coverage this way or that way, you have to document that you still meet the criteria. And even if you meet them, you may not remember when you get the thing in the mail to actually document. And a lot of people fall off coverage for that reason as well.
Why do we make it so difficult? I mean, you're arguing that it's unintentional, but I mean, is there
Yes.
some I mean, why would anybody oppose the elimination of a lot of these frictions? Do people think that that would result in higher expenditures?
I mean, you'd have to ask people who oppose it. I think a lot of it comes from a misconception that universal coverage means single payer or means more government provided insurance or less, So again, our view is, we've tried to cobble this together through the back door, through different programs for different people. Let's just, sort of clean slate it and do it, to do it sensibly and coherently. I think one of the objections we've heard, so there's two. One is about the cost, which you mentioned, and I'll get to in a second. The other one I've heard is, healthcare, as you said, is about $1 in $5 we spend, 20% of GDP. So it seems like, however bad the current system is, the idea that we're just suddenly going to replace 20% of GDP with an entirely new system, one could worry that that could really go off the rails. And there, for better or for worse, as we emphasize in the book, our proposal is not going to have any reason to change how healthcare is practiced and delivered. As I said, it's really just about the financing on the back end. That's for better for people who are worried about, disrupting 20% of the economy. It's also for worse because, as you mentioned at the outset of our conversation, there's a huge set of concerns about rising healthcare spending, inefficiency and waste in U.S. healthcare. These estimates that 40 to 50% of healthcare spending is wasted in the sense of not delivering benefits to patients. So we're not going to solve that problem because we think that's actually, as we discuss in the book, a harder problem to solve, but at least we're not going to disrupt the current provision of healthcare. So then how are we going to do it without increasing taxpayer spending? We do a very simple calculation in the book, which I at least found very eye-opening. So it's well known that the U.S. spends far more on healthcare as a share of our economy than other high-income countries. We spend, as you said, about 20%. I think actually it's like 18% right now of our economy on healthcare. Other high-income countries, the average is about 9%, so we spend twice as much. But it's also well known that while in most other countries the vast majority of healthcare spending is taxpayer financed, in the US we have a much greater role for private payments, and in fact only half of healthcare spending in the U.S. is taxpayer financed. Medicare, Medicaid, the tax subsidy for employer-provided health insurance. Well, we spend twice as much, but in other countries it's essentially all taxpayer financed, and in the U.S. only half of it's taxpayer financed, so half of twice as much is the same amount. In other words, other countries are spending 9% of GDP on taxpayer financed healthcare. We're spending 9% of GDP on taxpayer financed healthcare. We're spending another 9% on privately funded healthcare. Our proposal is to take the 9% of GDP we're already spending on taxpayer financed healthcare, and rather than spend most of it on, an extremely, we'll pay for anything, no holds barred type program through the Medicare system for the elderly and disabled, let's have a much more basic floor for everyone, with the option for those who are willing and able to supplement it. So you could think of our universal basic coverage as closer to Medicaid for all, the public health insurance program for low-income individuals in the United States. It would have no cost sharing, but it would have, longer wait times than people with private health insurance are currently accustomed to for non-urgent matters, similar to the wait times that the U.S. Congress has established for the Veterans Administration healthcare in the U.S. And it would, have maybe less non-medical amenities. We talk about examples in Singapore and Australia where the universal basic coverage gets you recovery in a hospital ward with 10 rooms to a bed and 10 beds to a room, and you can supplement with private insurance if you want a private room with your own bathroom and air conditioning. But it would get the job done in terms of providing essential medical care, and we estimate that about 2/3 of the population would supplement it, and they could. This could be done while maintaining their current insurance. They're just getting a voucher, as it were, for the basic part and just paying for the additional care.
Well, I mean, this is the part about the proposal that seems the most sensible, but also kind of the most unusual, because I've talked to a lot of people about problem of healthcare in the U.S., and it seems like almost everybody has this notion that healthcare is a human right and a need, but that everybody's entitled to, unlimited healthcare. And we don't think that way about anything else. I mean, even if we think that everyone deserves a roof over their head, we don't think that they deserve to live in, Mar-a-Lago, and we think that, everybody deserves to eat, but they don't necessarily deserve a 3 Michelin star. Why is it that we tend to think that all healthcare is you either need it or you don't need it? Why don't we view it the same way we view other kinds of economic goods, even necessities like food and shelter?
Yeah, no, you ask a really good question. I think, again, if we look at what is revealed by our policy actions, I'd say implicitly we do believe that what you're entitled to is essential medical care, not the Michelin restaurant equivalent, and that shows up in the form of longer wait times and less choice of doctor, etc. I think it's hard for people to consciously say that because health feels different. It feels like it sort of occupies a different space in the moral firmament. Certainly any caregiver or physician is not going to want to consciously, treat a patient differently based on their insurance coverage or lack thereof. But of course there are physicians that only accept certain insurance and not others. So whether or not we like it or not, I think it's a reality. As an economist, I feel that to the extent we want more equitable distribution of resources, we should do that through the tax system, do more transfers to low-income individuals. That's separate from the question of providing an essential floor on healthcare. The other thing I'd say, going back to this idea that health is different and it is sort of just occupies a different sort of moral space than food or housing, and I agree with you. I'm not sure why that would be. They're all sort of essential to leading a decent life. But one thing we talk about in the book is that for people who are dismayed about not only the poor quality of health outcomes in the United States, despite all the money we spend, but also the shockingly large disparities that exist in health across the income distribution and between Black and white Americans, somewhat counterintuitively, we argue that if that's what you're motivated for policy to solve, then health insurance is just not the policy lever you should be leaning on. That yes, of course, health insurance does increase access to healthcare, and healthcare is good for health, but empirically, quantitatively, the vast differences in health that exist across the income distribution and by race, very little of that would be closed by universal health insurance coverage. Not because healthcare isn't important for health, of course it is, but because that we already have this implicit contract that we try not to let people die in the streets, as it were. We try to provide access to essential medical care when people are sufficiently ill. And so as a result, the people who are nominally uninsured actually get a fair amount of health care. They get about 80% as much health care as they would get, we've estimated, if they were insured, and they pay for only about 20 cents on the dollar of that care. The rest is paid for, by taxpayer finance programs that are designed to provide indigent care, when essential. So, as I said, we're already paying for it. We're just and trying to provide it. We're just not quite getting it. And if you really want to deal with health inequality, the policy levers we need to think about are ones that attack what's known as the social determinants of health, the air we breathe, the cigarettes we do or do not smoke, the violence we are or are not exposed to, etc. In fact, I think one of the things that there's a huge body of work on this, but one of the things that I think drove this really home to me is research that others have done showing that even in countries like Norway and Sweden, which not only have a cradle to the grave social safety net that's much more comprehensive than what we have in the United States, but also have universal health insurance, you still see vast disparities in life expectancy across the income distribution. And that seems to be about access to information and health behaviors and whatnot. So really, it's not that public policy can't improve health and reduce health disparities, but it's not really about health insurance or even medical care. It's much more about these other determinants of health. In fact, one of my economist colleagues, Adriana Yaras-Muni, has this wonderful line where she says, something like, I'm going to paraphrase, getting good medical care when you have a heart attack is very important to your health, but not having a heart attack is even more important for your health. And that's like the pre-medical component.
Mm-hmm. Well, let's suppose we did set up a system where we had universal basic coverage, taxpayer financed, available to all. But then people could presumably supplement it, right, by buying the Cadillac if they want it, right? If you want to have
Absolutely.
your own room in the hospital with fancy meals and specialized attention, then you could pay for that, right? But in some countries like Canada, they don't allow that, right? I mean, is that driven by a concern that if people can opt out of the system, they will not support spending?
Sorry,
I mean,
you cut out. You cut out for a second. I couldn't hear
okay.
you. Is that driven by what? Sorry.
So the question is that driven by a concern or worry that the people who are buying the Cadillac plans would not support public spending? I mean, that's the argument with education, right? If the wealthy send their kids to private schools, then they're going to vote down any expenditure on the public schools, right?
Yeah, this is a really good point, and we spend an entire chapter in the book grappling with it. As I said, I'm not particularly concerned about people who say, oh, your system where people can top up will create a two-tier system. Like, whatever, we have a multi-tier system already, and at some level that's how we do everything. We have police protection, but then people buy private security cameras. We have, et cetera, et cetera. I'm much more concerned about exactly the point you raised, that the existence of the supplemental system could undermine or erode the adequacy of the basic system. And I think there's two ways that could happen. One, which you already alluded to, is in a political economy sense, that if, the highest income individuals are supplementing, and as I said, we estimate about 2/3 of the population would supplement, that will reduce sort of political support to fund the basic system at an adequate level. And the other is more of a just, sort of, I think, economic point, which is, if as a physician you can get paid more in the supplemental market, will we, not have enough high quality physicians, high quality hospitals providing care, for people with basic coverage. These are very real concerns, and we know they're real concerns because we've seen how this has played out around the world. For example, in many Latin American countries, the situation is sometimes referred to as, medical apartheid, that the basic system is completely inadequate. Anybody who can possibly afford to would, flee immediately to the supplemental system, and the basic system is really just inadequate. In other countries like Australia, Singapore, Israel, you see a robust basic system coinciding with a very active and large supplemental system. In fact, in Australia, far from worrying that the supplemental system will erode the adequacy of the basic system, the Australian government actually tax subsidizes higher income individuals to encourage them to buy supplemental coverage, because they feel that that cross subsidizes and props up the basic system. It alleviates pressure on the government budget. We don't have the secret sauce to know how you end up like Australia as opposed to, Argentina, for example. But, one thing we talk about in the book is we've seen how countries have, like Israel, like the UK, like Finland, have responded when the basic system starts to erode in adequacy. It's not rocket science. It is basic economics. They increase funding for the basic system, and they put in place a series of regulations and financial incentives to make it very unattractive for physicians to practice solely in the supplemental market. So most practice in both. And at the end of the day, you mentioned Canada, but at the end of the day, it's really just a few Canadian provinces, North Korea and Cuba, who outlaw supplemental coverage that could also cover what was nominally covered by the basic system as well. So it's sort of, everyone seems to have some version of it, and the key is to make sure that you put in place systems to maintain the adequacy of the basic system, which, as I said, some countries have done more successfully than others. And we talk about what the ingredients we think are, but if there's one major concern I would have with our proposal, it's how do we make sure, in a political sense, which is way beyond our expertise, that those safeguards are in place to make sure that the basic system remains adequate.
Now, you mentioned that the government currently spends 9% of GDP on healthcare. Does that include the foregone tax revenue from the deductibility of the healthcare expenditure paid by private parties?
Yes, so the biggest expenses are public spending on Medicare, the public health insurance for the elderly and disabled, and Medicaid, the public health insurance for low-income individuals. But the next biggest chunk is, as you referred to, the fact that if your employer pays you in the form of contributions to your health insurance rather than wages, well, you have to pay tax on any wages you get, but you don't pay tax on any payments he makes for your health insurance. We would be replacing that in some sense with an automatic, everyone has the equivalent of basic coverage, which you could then contribute towards buying a supplemental plan if you wanted. This is actually how the Medicare program currently works. It's somewhat ironic, to me at least, hearing all the arguments about a public option in the Affordable Care Act on the exchanges, that in fact the way the Medicare program currently works is essentially what we're proposing. Everyone, when they're 65, is automatically enrolled essentially in hospital and physician insurance that's publicly provided. That's traditional Medicare. But individuals who want to can opt out into a alternative private insurer as long as they provide at least what the traditional Medicare program provides. And if they opt out, the government pays the private insurer essentially a voucher that's equal to how much they expected to spend on this individual had they remained in the traditional system. And now we have close to half of the Medicare population covered by these private so-called Medicare Advantage plans. And that's basically what we're proposing, just for everyone, that everyone in some sense you could think of is automatically covered with a basic plan, a much more basic plan than Medicare. But then if they want to, buy their current plan or something else like it, they would simply opt out of the automatic public option and take with them a voucher that equal to how much the government estimates it would have spent on them, that they can apply towards, a supplemental private coverage that has to cover at least what the basic would have covered, but can cover more at higher cost.
Now you point out that that would lead to some adverse selection, right? Where these private companies would try to attract the healthiest people, right?
Yes, and
leave.
as you said, that we have a whole other book on that subject. Adverse selection is sort of the first topic I studied in economics, and as I said, Ron and I worked on it for years. We wrote a whole book on it with Ray Visman. It's a real problem, but it also has real solutions. And as we talk about with the example of traditional Medicare and the opt-out to Medicare Advantage, yes, Medicare Advantage does manage to cream skim patients who are less expensive than you would have predicted. They have creative ways of doing it, like offering discounted gym memberships, not because going to the gym makes you healthy, but because that's more appealing to someone who at least can pretend to themselves that they're going to go to that gym. But at the end of the day, it's a relatively small problem compared to the bigger one we're dealing with. Or, put differently, we're not going to let the perfect be the enemy of the good. We have known solutions. The Medicare Advantage program itself has had a number of reforms that have reduced the ability for insurers to do this kind of cream skimming. For example, you used to be able to switch into Medicare Advantage anytime you wanted. So you'd wait till, or switch out of it. So you'd, wait till you got sick and then move back to the publicly funded one. Now you can only do that once a year. It's priced based on a wide variety of health conditions. I mean, there are, what's it someone said about government, that democracy is the worst form of government except for all the others. It's sort of how I feel about issues of selection in our plan. Yes, it's a problem, but it's the worst problem except for all the others in the other proposals.
Well, if we did split it up so that we had universal basic taxpayer funded healthcare, and then you could supplement it with additional insurance, is there any reason why that additional premium ought to be tax deductible the way health
No.
expenditures are now? And we don't have deductible rent and deductible food and
Well, we do have a
deductible.
mortgage deduction, but I'm not sure
Yes.
that's a good idea either. I think
Right.
no, I don't see any reason. Well, I don't see any reason for separately. I've written on the current, even in the current system, why we have a tax exclusion for employer provided health insurance. It encourages sort of employers to over pad the health insurance relative to wages more than people value. It's incredibly regressive because not only are higher income people more likely to be in firms that offer employer provided health insurance, but the value of the tax subsidy, it's being able to not have to pay taxes, which is more valuable if you're higher income because you have a higher tax rate. So there's many reasons that it's I think universally reviled among economists.
Now, I wonder if this would be a stable equilibrium, because there are going to be quite a few people that are going to be unable to purchase this supplemental insurance, right? Because of, concerns about adverse selection. And so they might be clamoring for some government provided premium health care, right? I mean, we'd still have this problem of unraveling in the private markets, wouldn't we?
Yeah, although I mean, I'm sure there would be some, but again, first of all, we would have a floor that everyone would have, the universal basic coverage, and as I said, there's a lot that can be done to prevent markets from unraveling. As I said, don't get me wrong, adverse selection is a problem, and it's one we need to be vigilant to, but I don't think it's a reason to either outlaw supplemental coverage or to not have a basic floor for everyone.
Sure, but there'll be people who are going to want premium care. They're not going to be able to get it because the insurance companies will not provide it, and so they're going to lobby their congressmen for coverage on those premium packages.
Yeah, as I said, if you look at countries that have the type of system we're talking about, Singapore, Australia, Switzerland, Netherlands, Netherlands is very similar to what we're proposing. There's an automatic universal basic coverage. This is all provided by private insurers, or you can purchase more. And a lot of people do purchase more. So it hasn't empirically completely unraveled.
Well, would the costs
And there
go
are
down
things
as a
like
result?
no.
I mean,
We're
if we don't
arguing that
have,
we wouldn't have to raise taxes to provide a universal basic coverage that fulfills sort of our commitment to access to essential medical care regardless of resources, but we're not arguing, nor do I think it would be true that this is actually going to save money. But again, I think this notion when people advocate we're going to do something to save money, so often that's both a bit of a stretch, but it's also kind of, I think, a bit of a distraction in the sense of the purpose of most policies is not to save money, it's to accomplish an objective, and we pay for that objective. We don't say we're having national defense to save money, we're having it to be, secure. Similarly, the purpose of health insurance is not to save money, it's always nice if you do, but it's to ensure access to essential medical care regardless of resources.
and what I meant was that if you had this supplemental private market, then presumably all of those different private companies could tier themselves, and you could have some that would say these things we're not going to pay for. We're not going to pay for the $100,000 a week cancer treatment. If you're going to go for us, you don't get that. And whereas right now, if something is approved by Medicare, then every health insurance company has to provide that, right? So you would essentially be allowing these private policy providers to have more restrictive policies on what they would spend, and that would presumably provide less encouragement for the development of expensive procedures and treatments and
I
pharmaceuticals. Right?
I think that's right, with the important sort of qualifier that we're only going to give insurers choice over whether to cover things that we don't feel are essential medical care. Because if we do, then if the insurer doesn't cover it and the person gets ill, the taxpayer is going to feel they need to step in and have, charity care to provide it. But yes, then it becomes, it becomes a question of what is it people want who have the money to buy additional insurance, if that's what they want to spend it on, how quote unquote gold plated does it, do we want it to be?
Mm-hmm. And so I think part of the story you were describing is that the rise in insurance has led to a rise in investment in the development of these very expensive procedures and treatments, and there doesn't seem to be any kind of price pressure or need to have some restraint on pricing for these procedures and products.
Yes, I mean, I think the question of getting the optimal amount of medical innovation is a very challenging one. It's not clear we get that right even in the absence of insurance. There's both concerns you can get too much innovation, because part of what I get when I invent a better medical device is I get, all the market that the previous medical device had, as well as any incremental improvements. There's also concern we get too little medical innovation because, the innovator doesn't capture all of the gains and surplus through the innovation. But in some sense, to me, that's a very important but distinct issue from how we finance it, through the insurance system.
Well, are there any ways to develop incentives to get people to invest in their health, to invest in lifestyle choices that may reduce overall expenditures?
That is another great question. I think, again, this gets out of the realm of health insurance and more into understanding, the demand for, help, preventive care and investment. This is not my area of expertise, but I think that in general, there's a sense that, it's hard to get people to, say, take their statins to, lower their cholesterol after a heart attack, even if those statins are free. So it's not about financing. And why? One of the theories is, well, you've got a lot going on in your life, and when you don't take the statin, there's no immediate feedback loop. You don't immediately have a heart attack. And so you don't see the benefit, and that makes it harder to remember. I think, one of the things that's going to be very interesting with these new weight loss drugs is those seem to be very different in the sense of you go off of them and immediately, there are consequences. So that, not that I'm arguing that we should, give people heart attacks when they stop taking their statins, but it may be that part of the reason it's hard to get people to invest in preventive care is because the returns are not so salient or obvious. You have to, believe the evidence and remember it all the time, as opposed to seeing with your own eyes what's happening when you change your behavior.
Well, I think you quoted somebody who said that something to the effect that a revolution is never expected until it's inevitable. So, I don't think anybody is going to be expecting this kind of revolution anytime soon, but maybe we'll be surprised and we might see it happen.
I mean, I think it can't happen until you at least start talking about it. And we're certainly neither skilled nor savvy in the political sphere, but our hope in writing this book and in being on podcasts such as yours is to get the ideas out there, hopefully convince others, maybe sell a few books in the process, and so keep those ideas alive until either a policy window opens or enterprising people who read this book and are working in the policy sphere figure out how to make that policy window happen.
Well, Amy, thanks so much for joining me. The book is called We've Got You Covered, Rebooting American Healthcare. Thanks so much.
Thank you so much.
Unsiloed podcast is produced by University FM, elevating the stories of your institution.